morning to all the esteemed panelists and welcome to the day 2 of APAC HealthTech Innovation Conclave Focus South. Yesterday on day 1, we had a very insightful and interesting discussion by various key policymakers about digital strategies for transforming public health in India, as well as how hospitals are deploying technology to improve the health infrastructure. Today, on day 2 of the conclave, we have the very first panel discussion on care management best practices for improving patient care, safety, engagement, and experience for better outcome. Let me welcome the esteemed panelists for this particular panel discussion first. We have Mr. Abdullah Saleem, Group CIO of OMNI Hospitals. We welcome you, sir.
Thank you.
Then we have Dr. Gayathri Kamineni, COO of Kamineni Hospitals. We welcome you, ma'am.
Thank you very much.
We have Dr. Sanjeev Singh, Resident Medical Director, Amrita Hospitals, Faridabad. We welcome you, sir.
Good morning.
We have Dr. Chandrika Kambam, Director, Clinical Services, STG Group of Hospitals. We welcome you, ma'am.
Good morning. Thank you.
Last but not the least, the moderator of this panel discussion, Mr. Devanand KT, Regional CEO, Telangana and Andhra Pradesh Cluster, Aster DM Healthcare. Over to you, sir.
Yeah, good morning. Good morning. Thank you. So good morning, everyone. It's a very, very exciting day for me, especially to moderate such an esteemed panel. The panelists come with, diversified experience. We have founders. We have, representing the founders there. We have Dr. Gayathri and Dr. Sanjeev comes with a lot of experience. Dr. Chandrika also comes with a diversified experience in multiple bigger healthcare organizations. And we also have a CIO here who will talk about more about the technology. So both the panel becomes more interesting when the panelists also have that kind of a varied experience. At the same time, the subject is also, a very interesting topic. So today we'll be talking about the most important part of the care for the patients. Initially, when healthcare started, we were focusing only on the care of the patients. Then it moved into patient safety, then engagement, then experience. So now all these four constitute an important, all these constitute important factors in the entire patient journey inside any healthcare organization. So now we will ask the panelists on their opinion how they look at all these aspects in giving the best care or giving the best experience to the patient. So I'll start my first question to Dr. Sanjeev Singh, who has been doing a lot of work in this particular area, especially in patient experience and also the prompts and frame that we talk usually. So that I think he'll give more details later. But my question, sir, to you is when we consider the engagement, experience, care, and safety, which do you think has got the most, or should we focus more, or what should be the priority order of this according to you? If you can just give us your insights about that.
Yeah, thank you, Mr. Devanand, and very excited to be part of this esteemed panel. So I think it is important first that we need to provide the care which is a clinical care delivered at the bedside, which would include both diagnostic and therapeutic. So until unless that is delivered properly, which is evidence-based, which is scientific, which is as per the updated recommendation, it is not going to make sense. So first, the prevention and the therapy is going to be very important. So we should look at the diagnostic stewardship, whether appropriateness of the investigations. We need to ask the history of present illness, and based on that, do a confirmatory diagnostics, imaging, and look at empirical and then the targeted therapy. So care, I would prioritize, would be the most important because that would be the leading point, and that is why the patient is basically coming to seek health care in the hospitals. So once that is done, it needs to be also provided with adequate measures of safety. So both clinical, non-clinical team should do the risk assessments and risk managements at all point of time. It is important for each patient. So you need to take care of whether it is bed sores or medication errors or medical errors or following a patient towards the surgical pathways and providing the surgical and anesthesia safety, procedural safety, and things like that. Once you are very good with providing medical care, you are provided a safe care, you need to engage with the patient because there needs to be an informed decision making. And we have used some of these ethnographic tools in our hospital. There's a fantastic tool which is called a Sociogram. And we saw that the care is very hierarchical in nature. The head of department comes, he seeks the patient information, and then there is most of the talk which happens. And unfortunately, in India, it is more of carer rather than patient centric hospital, because carer participates more than the patient. And that's how it is, because he or she carries most of this patient related information. So we need to change that. We need to engage more with the patient, provide him what has been planned, and then informed decision making should take place. Once you are good with care, once you are providing a safe care, you have engaged with the patient, it is important that the experience both for a carer and for the patient should be good. And that means that the look and feel of whatever you have provided is good. There is a dignity to the patient, there is adequate respect, there is adequate communication which is effective. So we need to do the reflective exercise off and on to see whether they have understood what you want to deliver, and not just providing hope and not doing an effective communication. So I'd like to prioritize as care, safety, engagement, and experience.
Yes, thank you, Dr. Sanjeev. That is, we will come back to you on a few points that you have mentioned, especially on the stewardship and also the sociogram, which looks very interesting to discuss. So we will go with the same question to Dr. Gayathri. She represents Kamineni group, which manages a large number of beds, 1,600 beds, if I'm not wrong. So she has also been involved in so many patient improvement initiatives in her group. So Dr. Gayathri, the same question is posed to you. Do you have any change in the priority order, or would you like to go with what Dr. Sanjeev has mentioned?
Thank you for the question. This is something that we hold very close to our hearts, the patient experience aspect of it. There is a small change in my priority compared to what Dr. Sanjeev has. So I would actually put my priority as safety first. It's a very cliche thing to say when it comes to healthcare, but we need to understand that maintaining protocols, to have safety embedded into the staff, embedded into whatever we are doing, whether it is touch, whether the patient is on the bed, whether the railings are up, whether the restraint has been done properly, whether the gloves have been worn by the nurse. That is something that we have to keep. That is what I feel that has to come as number one on the priority list. The second one coming, obviously, that is care. Care is something that we have to include engagement together. So care and engagement have to go hand in hand. Care is where we set up protocols, where the doctors come into the picture, where everything else is falling into line. But along with care, engagement is something that has to go hand in hand, as engagement means a person responsible for that patient. It need not be that there is a manager allocated to the particular patient. Every person, every touch point in the hospital is responsible for the patient. So when we are looking at whether it is a housekeeping person who's pushing the trolley, or who's pushing the wheelchair, whether it is a nurse who's talking to the attendant or to the patient, taking consents, the way we explain to the patient, the way we tell them that, okay, listen, so this is what is going to happen right now. Are you okay with it? That is the engagement. That is what we are talking about. We are going to tell them what is going to happen. It so happens so frequently that we miss out on actually telling people what is going to happen to them in a hospital. We are very happy when it comes when we know that what is going to happen to our appointment in a spa, or in a hotel, or when we reserve a table in a hotel. We feel very happy, but that's a very small thing, right? That is by choice. But this is something that we have to go through it. And we can't expect a patient or an attendant to just say yes, 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 yes for everything and just go forward with it. Okay, fine, now it has to happen to me, so it's going to happen to me. That's it. No. We have to tell patients, we have to tell the attendants what is going to happen, and then also tell them what has happened. So for me, first is safety, then care and engagement together. All these together actually form patient experience. You have to think of your hospital or your healthcare delivery system as just a patient-centric system where you only look at the patient comes into the hospital, you treat the patient, you give a proper diagnosis, you give the treatment, and then the patient is out. You either do it that way, or you look at your hospital being a place where you deliver patient experience, where you give an experience to the patient so that the patient comes back to you. There have been places where you're looking at where the hospital looks like a 5-star hotel, where the rooms are suite rooms, where you have like 1, 2, and you have like a kitchen and a kitchenette, where you have a butler kind of a service. Yes, those are available for people to afford, but that's not the majority that we are looking at. We are supposed to look at patient experience. If I was in the hospital, what would happen to me? What would I want to happen to me? What would I want to know? That is what patient experience means. So putting yourself in the shoes of the patient and the patient attendants, that is what patient experience has to go through for us to understand. So for me, experience involves all, everyone and everything, right? So at the core, there needs to be a change in culture. There needs to be continuous staff training, and more importantly, your heart and soul of the hospital, your IT structure. Your IT is the backbone of the hospital. Your IT is something, your IT and your nurses. I'm going to put the doctors aside in this discussion. Your IT and your nurses are the backbone for the hospital. If your IT and the nurses are working hand in hand and they're doing a very good job at it, you're done with delivering patient experience as a whole, which also includes the staff training and more importantly, the culture of yes, let's go ahead and do it. So yeah, that's my priority list.
Yeah, thank you, Dr. Gayathri. Thank you so much. So we will come back to you on some IT initiatives that you're taking, which gives that wow feeling for the patients. Or is there any specific nursing skills that you impart to the nurses to make the experience for the patients better? So we'll come back to you at a later stage.
Sure. Yeah.
So now both the panelists have been mentioning that in order of priority, probably yes, care has become 1 or 2, but patient care remains the core in the top priority list for any healthcare provider. So I take this question to the next panelist, Dr. Chandrika. So Dr. Chandrika, she represents HCG and she handles the clinical services for the entire group. So care must be a top priority for her, no doubt about it. So what do you think, Doctor? Patient care has evolved. What are things new means? Is there any a new evolution for the patient care that has evolved, or is it the same way that we are providing for years? The same way it's been continued, or is it that we have looked at a new means to give our patient care? What's the response on that?
Yeah, good morning, everyone, and thank you, APAC, for inviting me to be on this panel. And as my predecessors, Sanjeev, Dr. Sanjeev, and Dr. Gayathri mentioned, the patient care is a holistic approach where you look at safety, the experience, and outcomes, and everything. So, since Gayatri said she will put the doctors aside, so let me take up the part of the doctors, which is so very important when it comes to patient care. So there are two aspects that I would like to touch upon, which is like a backbone of patient care. That is outcomes. One is outcomes, and second is engagement. So, how do we do this, and what are the means that are there to improve the patient care, thereby improving the patient outcome, thereby improving the patient care? So, there are 7 pointers I would like to touch upon. Number one is correct diagnosis. I think Dr. Sanjeev briefly touched upon the importance of taking the correct history, coming to a proper differential diagnosis, ordering proper diagnostic tests is very important for doctors. when they are dealing with patient and trying to improve the outcomes. It has been said that number one malpractice claims in the US are due to diagnostic errors. So you can imagine the importance that we have to place in proper diagnosis of a patient. So that is point number one. Point number two, once we have the diagnosis, we need to implement the right treatment. Gone are the days when people used to do solo practice. I'm the physician, I'm the cardiologist, I'm the pulmonologist, I do everything. So this is not going to hold waters anymore. The doctors have to work together as a team, and they should know what is the limitations of each of their specialities and consult the appropriate super specialty or the other specialities in taking care of their patients. There is no if, there should not be anything other than the patient care that comes first. We should not put anything other than patient care in the center of this whole thing. We should not think that what will patient think if I refer a patient to another doctor. That is not important here. What is important is that we are providing the correct care to the patient at the correct time. Use the electronic medical records so that the care can be coordinated better, and we know what the other doctors and other ancillary services are doing, so that we can give a comprehensive care to the patient. So point number 2 is correct treatment. Point number 3 is the better care of the clinical team themselves. So as administrators, they should understand that the doctors and the clinical team are going through a lot of stress when they are dealing with patients. So we need to ensure that we provide a good environment for them where they can think clearly, act accordingly, and provide care that is that is world class. So it is very important that we look at staffing, the number of nurses that are there, the number of front desk people that are there, the supportive staff for for doctors in following up of the patient, so on and so forth. So it is very important that we give that. That is point number 3. Take care of your clinical team. Point number 4 is to measure your outcomes. It is very well known that what you measure gets what gets improved. What gets improved is what you actually measure. So you need to measure your outcomes. Only then you will be able to make or take the corrective steps to see where you are, what you're doing, and how you can improve the patient outcomes and thereby improving the patient care. So that is point number 4. Point number 5 is ensure continuity of care after discharge. No longer the doctor's work or the hospital work ends after the patient is discharged. Actually, it starts after the patient is discharged, because most of the time, 90% of the time, the patient forgets what you have told them at the time of discharge. When they go home, they're totally confused, especially if they are on multiple medications, if they have to follow multiple regimes, diet, etc., etc., etc. So it is very important that we engage with them, especially in the first few days after discharge, so that they understand what they're supposed to be doing. And in many countries, Western countries, especially in the US, now they look at a readmission rate within 30 days. Hospitals are penalized if the readmission rate is high. And in the survey, it is shown that out of 3,400 providers, 2,500 providers were penalized for readmissions. That means they did not follow protocols that were required to help patients after discharge. So engage with your patients after discharge. That is point number 5 and 6. And lastly, the point number 7 is the IT infrastructure. It is very important that we leverage IT infrastructure. There is ocean of development that has happened in the last 10 years in healthcare in terms of IT. There are Bluetooth enabled devices, there are IoTs, there are apps, you name it, we have it, but we are not using it adequately and in the right manner to improve the patient outcomes. So it is known in a survey that 82% of the doctors feel that if the patient inputs their own data and engage, they understand their disease better, and they also kind of engage in the treatment aspects better. So encourage patients to input their own clinical symptoms, input their own sugar monitoring, sugar readings, etc., etc. Engage them through these technology-enabled devices so that they understand their diseases and thereby help you in following and making sure they follow the treatment protocols and thereby improving the patient care. So these are some of the 7 pointers I would like to bring upon, which are related to clinical care. Of course, there are a lot of non-clinical areas of patient engagement, which is very core. That is waiting time, empathy, providing the service, response time, being proactive to their needs, etc., etc., which are also very important. So these are some of the areas that I feel
Thank
that
you.
we should
Thank you,
work
Dr.
on
Chandrika. I think
work
that's
on in order to improve the patient care. Thank
yeah.
you.
Thank you, Dr. Chandrika. That was very elaborate and precise. So you ended your pointers by saying that developing IT infrastructure is a very important thing in the patient care now, patient care, or even in terms of experience or engagement. IT plays a vital role, which Dr. Gayathri also mentioned in her when she was given her opinion. So we have none other than Mr. Abdullah Saleem, who's actually the representative of the technology side of it. We have a CIO. He's as a CEO, is implementing a lot of technological initiatives in developing the IT infrastructure for healthcare. So, Mr. Saleem, the same thing, the same question that I asked Dr. Chandrika, I want to give it to you. And we would like you to give a IT perspective of the entire patient care. So if you may give your response, please.
Thank you very much, Mr. Devanand. I think Dr. Sanjeev, Dr. Gayathri, Dr. Chandrika has added all the information and added a lot of valuable inputs in terms of information, and that has made my life easy to make it a bit shorter. Though I come from the technology background and working for the past 2.5 decades in healthcare only to try to ensure that the hospitals are enabled and the IT infrastructure, the IT wing is one of the core enabler to run their business. Now we have reached to that level, and that understanding has come across the industry thanks to the pandemic era, and that's the reason that it has enforced the hospitals, doctors, patients to rely on the technology. So, as per my understanding, as I said, that for the past 2.5 decades, I'm there, and I'm just trying to see that in 2002, 2003, and until 2011, when we were trying to do a change management across the country to deploy the EMR, and the kind of challenges we faced, I hope those challenges has been mitigated in last couple of years. So, as per the technology, without technology adopting the patient care, safe patient care is impossible. That is proven, and that is understood by the industry of Indian industry as well, though it was not earlier. So if we'll see that if we're talking about the patient safety and patient care and patient engagement and better outcome, without technology, adopting the technology is not possible. Again, the technology is not going to play a magic role unless the right people, right process has been put in place. So if I'll say that if 100% out of 100%, if three components divide, 35% is take care of the right people, selection of the right people of the organization, including clinical paramedical staff, and then your processes have been put in place, and that is again cater 35%. And these people and process which caters 70%, that is the challenges which has been addressed up to some extent, and I'm sure that it will keep improving down the line. And then 30% is the technology which is going to play a role. So the technology was not the challenge. The challenge was the 70%, right people, right process, and the technology. So, so if it is there in place, then the enabling and the better outcome to ensure that the patients does not need any kind of your huge digital marketing expenses, referral kind of business the hospital does from with the GPs. A lot of money is being paid from the snatching the money from the pocket of the paying people and the that is the patient. So this is what I come and put my thought process. Apart from this, I'll just add a few bulleted points on this. That if you're talking about a new normal and the way forward to better patient care, patient safety, and patient delights. So the technology is going to help a lot into that, which is going to enable a remote healthcare provided by telehealth. Means it is going to help with a better ROI. Digital health transformation will be a key priority across the industry, whether it is private or public kind of hospitals. Increased focus to preventive care and public health care. It's not possible without putting technology in place. Social media to continue influencing, it will be there again. The technology will come there. Fortifying infection control measures. Without technology, it is impossible. If a guy who is there in the ICU and is being treated and he's got pneumonia, so that has to be monitored very closely. So without clinical application put in place, it is impossible to talk about the clinical risk and take the preventive action. Then optimizing the workforce. For example, tele-ICU in pandemic, that has been proven. That is, again, the technology is going to add into that to improve the outcome of the hospital. More spending on the healthcare and wellness. This is what is going to be happen down the line. And healthcare can be flexible and faster. If you want to make it flexible and faster, without technology, without adopting the EMR, EHR, PHR, it is impossible. However, pre-COVID, the healthcare organization, investors, governments, and regulatory bodies were not fully convinced about the potential of those innovations, that is technology. Hence, the cry of changes is bringing real value in the form of improved efficiency, experience, and outcome. The pandemic has been a wake-up call, and industry is going back to normal that is stronger, smarter, and healthier. And in other words, adopting technology means there will not be any choice to the healthcare organization, healthcare providers to ignore it. Over to you, Devanand.
Thank you, Mr. Saleem. I think with no technology, you can't exist. That's what your tagline says, right? And you also made a point that right people, right process, and right technology, almost like a democratic statement you have made. So technology has come as an important part in that. So, without technology, we will fail in moving forward.
I have tried when we are deploying first EMR across the max group of hospital, and only the cost of implementation, excluding the infrastructure, was 121 crores in 2000 and 2009. And now this adoption of the clinical adoption, if you talk about, go and see that how the point of care is improved. I mean to say that.
Yes, thank you. So now all the panelists have been mentioning about the experience and engagement. Now, I know Dr. Sanjeev Singh has been a great proponent of the PROM and PRAME, the patient-reported experience measure and the patient-reported outcome measure. So how effectively, Doctor, I know that you have also taken a lot of sessions on this particular two topics. I think it's very close to your heart. So we would like to hear from you how effectively these outcome measures, how effectively these experience measures are monitored, and how effectively you are implementing at your organization.
Yeah, thanks, Mr. Devanand. I think it is important. It's a good tool. So, very interestingly, there is a surgeon, Dr. Ernest Codman. 100 years back at Harvard Medical School, said that we need to follow patients longer enough to understand whether we are delivering proper care. 100 years back. Right now, a lot of surgeons or physicians would suggest that their CABG, solid organ transplantation, or TKR, THR success rate is 97%, 98%. That's a surgeon's perspective till the patient gets discharged. So there is a new tool where the patient needs to contribute towards the success measure of any procedure. And there is where the International Confederation for Health Outcome Monitoring and Harvard Business School came together almost a decade back, and they adopted a tool which is called as patient reported outcome and patient experience monitoring measures. And so if you get a TKR or a THR done, you get this, you're introduced to this tool. You are followed at the time of discharge, 3 months, 6 months, 1 year, and 2 years. There is a particular order set. ICOM has developed close to 54 order sets, which is very popular, and that's how the Center for Medicare, Medicaid now make their payments and do the value-based purchasing, because the patient needs to participate in this journey to say that the procedure was appropriate. How do they say? There are many tools. So there are hip arthritis, osteoarthritis scoring system, whose there is a knee osteoarthritis scoring system, whose there are EQ, 5D, 5L quality of life formats for CABG, for lap colis, for bariatric surgery, for so many procedures. So we have used this since 2016 onwards on our antibiotic stewardship program, following up COPDs at critical care. We have looked at triple vessel disease and CABGs. We have looked at TKRs and THRs, knee replacements. So we have developed an app which is both English and in Malayalam, and we educate the patient when they get discharged, and we do a video consult and follow up on basically quality of life issues, looking at activity of daily living, their anxiety and depression scores. There is visual analog scores, and follow up till 1 to 2 years, and that is how the rating comes in. So if and we have seen that there is the experiences have been much better. There is close to 300 to 400% increase in these patients. The patients may not be revisiting us; they revisit. So there is an economic gain of close to 1.2 CR for us. Plus, I think it's a good tool. NABH in the fifth edition has also mentioned that this needs to be just raising the bar. They have adopted this tool as one of the safety measures and quality improvement initiative. So it's a good tool. We need to follow the quality of life measures and adopt and see whether we are making any difference to the patients.
Thank you, Dr. Sanjeev. So, could you also tell us something about the sociogram that you were mentioning during your initial comments?
Yeah, so there are quantitative and qualitative approach. In a qualitative approach, there are patient lived experience. So there is ethnographic study which you could do to understand are they happy, are they satisfied with the treatment, and things like that. So sociogram is one of the tools where we shadow the doctors, the clinical rounds, and look at the communication system. So we do that for most of our clinical departments because it's part of our one of our research study which we are doing with UK, South Africa, and Rwanda. And we see that ours is a not-for-profit university teaching hospital, but still many a times the care is hierarchical in nature. The head of department has asked most of the questions from the nursing staff or the senior resident, and the participation from the patients and the carer is less. So we shadow the doctor during the rounds, and we look at all the communication with respect to hygiene, stewardships, preventive measures, their care, their therapy, the diagnostics. What all did the clinical team communicate to the carer and the patient? And we see that though it's a Western concept of being patient-centric hospital, I am a very strong proponent, having seen sociogram, that in India it is more of carer-centric and then a patient-centric, because carer plays a huge role in the patient, and we need to really take care of this group of people who are sort of ignored. We we go back and put that as a map and go back to the clinical team and tell them that this is how you behave today. Though every clinical team assume or say that they are fantastic communicators, and we don't disagree, but we go back and very objectively show them that this is how you behave today and this is where you did not communicate. So initial 5-6 months were very tough, and they were volatile and violent to their behavior, that they have been shadowed and somebody is monitoring. But eventually, I think it was just a good decision-making exercise, and they participated. And now we do it with most of the surgical department, and we see that the behave, because you can keep training them. Training doesn't help until you change the behavior. And this is a behavioral change model which we thought we'll adopt.
Thank you, doctor. That was very interesting and very, very insightful. Also, thank you for that perspective. So we will go to Dr. Gayathri now. Dr. Gayathri, you were mentioning about giving that kind of wow experience to the patients in terms of the patient journey when they come into the hospital. You train the staff well, the nurses take care of the nurses well, they take care of the patients the most befitting manner, and with a proper IT structure, infrastructure in place, you want to give that kind of experience, which I'm sure you'll already be giving to your patients. So how are you ensuring that this experience can be remembered, or how can we give that kind of an experience which can be remembered by patients for a long time?
So I'll have a very strange comparison that I'm going to say right now. I'm not sure how many people are going to agree with that. So I look at hotels and hospitals at the same level. Okay. Hotels is by choice, hospitals is not by choice for people to come to, right? What kind of a hospital might not be a choice, but for some hotels are always a choice. So the instrumentation, the training of staff, for us, there are OT instruments, there are regular instruments and consumables and all that. The same thing is with the hotels also. But what is the difference between the two? It's not just by choice that I'm talking about. What is the difference between the two when you enter the hospital or into the hotel? There are people taking care of you from the second you put the foot into the hotel, right? Good morning, ma'am. How are you? Please welcome here, and on and all those things go on. But in a hospital, it's a different scenario when you come into the hospital. So for what have you come over here? Or which doctor would you want to see? No, those are not the things that patients these days or the patient attendants these days would want to experience. They don't want that. So what I would say is small things make a big impact. I understand where everybody is talking about doctor wait times, OT scheduling, being staff training, which is obviously very important, IT integration, emergency ward management. So these are the things which play a very big role. But for me, small things make a huge impact. Let's say, let's look at prioritizing age, right? There are people who stand in the line during the OP times where they have to take their OP card because now we have not yet converted ourselves. We have not yet changed onto the EMR module yet. So when we are standing in line, we look at mothers standing with their babies, old age, people with disability, pregnant women. For these kind of people, okay, you just change the line, you ask them to step aside, or you just make a new line. Just imagine the effect that it's going to have on people that, okay, fine, I am in a hospital, I am as equal to everybody else, but still they're giving me that importance. So that is what we need to look at. It's completely fine for another person. I completely understand that. Are we not a patient? Is what they're going to feel. But people will understand when you're looking at a baby and a mother, you're trying to give them priority. And especially during these times where COVID is still there, you cannot expect them to have a longer exposure period in the hospital. So these things play a very big role. Now, coming to the second part, listen. The staff has to be trained. The culture of the staff has to be literally it has to be ingrained into them, saying that listen to everyone, whether they are right or wrong, whether the conversation is going to be long or short, whether you're going to spend a lot more time with just one patient the whole day. No. Be patient with the patient. Be patient with everybody around the patient. The next thing that I would look at is, it might sound very, very silly and very small, but you need to understand the biggest thing for, like I told you, a comparison between a hotel and a hospital. I don't want to leave a hotel when I go there because they give me a very good experience and I want to stay. But I want to leave a hospital when I come to a hospital. I don't want to stay in a hospital, right? So we need to look at fastening the process of the discharge process. We at Kamineni, we make sure that the discharge is already told to the patient the day before they're actually planning a discharge, so that they're ready with what they have to pay, they're ready with the insurance details, they are ready with going home, so that they have their vehicle ready, their home ready for them to come home. So next day, whether they get discharged or not, the process is still there. We can take a decision tomorrow, but the process is still there. So the discharge summaries are done, the provisional discharge summaries are done, the pharmacy returns are done. So these take time if they are done on the same day, but they help if they are done the previous day, right? So they go on in the background. So we are reducing their time. Once discharge is there, no patient is going to wait in the hospital. They are going to be behind us. When are you discharging me? When are you discharging me? The most important one, like Dr. Sanjeev said, that yes, staff training is important. Yes, but at the same time, we cannot keep training them, training. It's not going to get us anywhere. We need to select people. We need to look at how, what kind of training is supposed to be given to what kind of people as well. They need to understand the subject of giving patient experience. They need to understand completely as to, if we go out of our way, what's going to happen, what impact is going to play on that patient. So like I said, small things make a big impact. I would actually congratulate many of our staff who have actually taken their own decisions, saying that this patient, the cab driver, because it's COVID, the cab driver, recently it has happened, the cab driver has refused to take this patient home because he's a patient, right? But my staff standing over there said that we'll send you in the hospital car. We'll send you in the company car. Please go home. This reach. So these are the small things. But the patient was so thankful. Came back. He was a dialysis patient. Came back 2 days later for dialysis. Came up to us and said that you've gone out of your way. Thank you so much. So I know that the patient is going to come back to me again. I know that the patient had a great experience. Giving the diagnosis also to a patient is an experience. I'm not sure if we are able to understand that. When I was in the UK, even a cancer patient being given a diagnosis takes it very, very well, because the level of empathy that the doctor has when he is explaining to the patient, when he or she is trying to tell the patient, see, here is what it is, this is what's going to happen, this is what we have options as, this is what you can take care, you can have, your treatment protocols are, this is how your treatment is going to go. So they show you a path. They tell you what support system you want as well. So that is very, very important when we tell patients. Patients don't need big, very luxurious things in the hospital. They know what they're coming in for, but there are basic necessities that we have to give them. Yes, but more importantly, what they need to get is, they need to be heard. That is the most important thing that we can look at. Obviously, IT plays a very big role. I don't have to tell, because there's Mr. Abdullah who can help us with that. But yeah, I think IT is one thing that actually keeps us in check. That is what we need to understand. It is definitely the backbone for the hospital. It keeps us in check. So integration of IT, staff training, culture, all these things play a very big role.
Thank you, Dr. Gayathri, for that wonderful insight. So I go to Dr. Chandrika now. So Dr. Sanjeev, when he was doing his work, he was mentioning about the importance of care continuum in the entire patient journey and the patient care journey. You are representing a group of hospitals which focuses on oncology. Oncology is something which now Dr. Gayathri also said, oncology is something where you need to have more empathy and more follow-ups, continuum or care. That care continuum has to be ensured so that the patient gets more satisfied. So is there something that you do in the care continuum part, especially in HCG, which really provides that kind of an experience or an engagement outcome for the patients?
Yes. Thank you for that question, Devanand. Definitely, just to give you a brief how this care continuum works in at HCG. Firstly, HCG has about 22 hospitals, out of which 20 are focused on cancer care, and we have around others multi-specialty hospitals. And as you know, the cancer is once it is diagnosed, the patient has to be followed over a period of time. We look at 5-year survival rate, we look at 10-year survival rate. So we want to ensure that we have a complete horizontal journey of a patient captured, and we are aware of what is happening to the patient at each stage, from diagnosis to the survival phase. So what we have done is, firstly we have tumor boards, we have multidisciplinary team meetings. Once the patient is diagnosed with cancer and comes into our system, there are a whole group of doctors who sit together and discuss what should be the treatment plan for this patient, what are the best treatment options that we can give for this patient, and including the genomic testing, the radionomics, and everything goes into the discussion. The discussion is not just with the medical oncologist, it has a surgical oncologist, nuclear medicine doctor, radiation oncologist, pathologist, radiologist, and genomic specialist. Everybody sit together and discuss about a patient treatment journey. Uh, uh, because of the advantage of network, we have that hub and spoke model, where even if one specialty doctor is not present in any of the centers, they can leverage the doctors that are present across the group, so that they can get the best inputs for a patient. And now with technology, we have all these Zoom calls, Google Meets, and the Teams. It is even more easy to discuss a case amongst all the doctors. So once the diagnosis is made and the treatment is finalized, then the patient goes through this journey of treatment, medical oncology, surgical oncology, radiation oncology, etc. So during this period, we have introduced a person called a nurse navigator. So the nurse navigator is independent of any specific doctor or a specialty. The nurse navigator for breast cancer means the work of the navigator is to ensure that the patient is going through that journey in an appropriate manner. So they follow the patient in a horizontal manner, not in a vertical manner. Vertical means medical oncology, surgical oncology, radiation oncology. So here the nurse is responsible for the horizontal journey of a patient, and she's specific for that cancer. So we have introduced that concept, so that is actually working quite well. So that does help us to ensure where is the patient along that journey and how the patient is doing at each stage. We also have home care, which kind of is inbuilt into our system, so that once the patient goes home, there is a very close coordination between the doctors and the home care nursing, because the nurses are part of that care team. So they know our system, they know how the hospital works, they know our doctors. So it is very easy for them to communicate with each other and follow the treatment protocols. So apart from that, we have medical social workers, physician assistants, like medical social workers who mainly deal with the social aspect of the patient, how to get them financing, how to get them understand the importance of the care, how to help them comply with a lot of other non-oncology related care, for example, nutrition. So there are many such aspects that they have to coordinate and take care of the patient. So there is people, the medical social worker who handhold the patient across the continuum of care. So these are some of the initiatives that we have taken in order to make sure that the patient understand the importance of each treatment protocol and how to go through that journey and handhold them across that journey. And we also have a cancer data registry that we maintain, where we call up patients at regular intervals to find out how they are doing. And we continue to do that for almost 10 years. So we have a data of all our patients across hospitals for the last 10 to 12 years, and we kind of follow up until they expire, to see what has been their length of survival. Has there been any recurrence? Has there been any new cancer come up in this patient? So there is in-depth analysis of each and every recurrence case, mortality case, and survival rate, rate that we follow up and look at our outcomes. So these are a couple of initiatives that we have taken in order to ensure the continuum of care is there, and thereby improving the patient care and outcomes.
Thank you, Dr. Chandrika. So looks interesting. Nurse Navigator is a good concept, unique concept that I'm hearing. So I think this is something which most of the hospitals anyway. Nurses are the people who communicate with the patient for the most of the time, so they get more accustomed to the nurses communicating with them even after discharge. So very well conceived concept anyway. So we will come back to you in case of other queries. So now we know that from all the other panelists that technology plays a vital role in everything. Not only in care. Dr. Gayathri also mentioned that technology plays a vital role in taking experience, providing probably all discharge summary. I don't know whether we can bring in that kind of an artificial intelligence to create a discharge summary for probably that also may come in future very soon. So discharge summary is something which blocks the entire discharge process, right? So once we can streamline that, that can really fasten the process. So a lot of technology related initiatives are coming. So in terms of initiatives, what do you think, Mr. Saleem, are the major technological tools or digital health tools that are really helping in this care, safety, engagement, experience, according to you?
Yes, of course. There is no, as I said, that there is no choice to avoid the digitization for the hospital. And just before I answer your question, I go back to the Dr. Chandrika. So she has added very well in the patient continuity and the patient engagement. Here, here at OMNI, we have just introduced that if the patient is also discharged and the patient is at home, and then we have given devices that is called clinic in bag, or you can say clinic in pocket. And that patient is keep being taken the almost 10 types of vitals, including the ECG and your blood sugar testing. And apart from the normal SpO2 and other normal regular vitals. And then in case of any abnormality happens, the patient family member gets notified, and the treating doctor is getting notified, and then the hospital get engaged immediately, and it start doing the teleconsultation on that platform, and then either they give the first aid in the VRs, and the next day they call for the in-person consultation. And because after every discharge, there is a first doctor calls for the review of after a week, after 10 days, and then that has been being totally made automated on top of it. And patient education in terms of keep sending across to them, patient engagement, patient educations that the guy is supposed diabetes mellitus, he's supposed to be check the foot check for every 6 months, and notification goes there, where the doctors also calls from the our doctor means the team, the clinical team calls to the patient and ensure that the patient is being taken care of his notifications, though it is her choice to go ahead or not. That is one part. And these kind of engagement is impossible to put the technology in place. And the other part I would like to add, this Dr. Gayathri was talking about, that as a whole, the patient experience perspective, patient experience perspective, basically that if the hospital is not compassionate means every individual who is interacting to the patient in the hospital, patient and patient parties in the hospital, if it is not being engaged with compassionate, then all these technologies, all these is not going to achieve the goal of the patient experience has been put in place and it is up to the mark. And patient being compassionate means every individual should be sympathetic, empathic. If they're not treating the sympathy and empathy, whether it's the doctor, your nurse, your ward boy, your paramedical staff, all these have to be have to have the sense of compassionate, and that kind of training is supposed to be given on regular basis to the entire hospital. And apart from this, if you see that the other countries, the developing countries like US, Europe, and I'm talking about the entire development country, they're spending a lot of money and a lot of time to ensure that the hospitals are falling under the compassionate protocol. And there are some regularities body who are just giving the training, who are auditing it, that whether you are compassionate or not, your hospital is compassionate or not, and they're giving the rating on top of it. So that's the key, and that will not replace the technology.
Thank you, Mr. Saleem. So I'm a little sad that a lot of questions to be asked, but then the time, due to the paucity of time, we may have to cut short a few questions. So there are a few questions by the participants who are watching the panel. So I may have to cut down my questions from the moderator side. I would like to take the questions from the participants, and I request panelists to take on. So this question, first question, this is not mentioned to anyone, so it's a general question. So I would like to pose this to Dr. Sanjeev. Basically, you are the chairman of the technical committee of NABH. So this, I think, probably has a medical legal aspect. During the pandemic, telemedicine, telehealth got accelerated. Just before the pandemic started, the telemedicine guidelines were also passed. Now in telemedicine, besides technology, there is a medical legal aspect also involved. How can hospitals take care of safe customer engagement in these circumstances? So, Dr. Sanjeev.
So very interestingly, this was all before COVID. So National Medical Commission, they drafted this guideline, and it was very well done. It quickly was adopted by Ministry of Health and Family Welfare, and it has been passed as an act. So now, before pre-COVID, any telemedicine has been there for almost 3 to 4 decades, which was not medico-legally acceptable. But now, since this act is there, and there is, and it comes also from Ministry of Health and National Medical Commission, which is an autonomous body, now, the doctors are protected. So it is medico-legally, the advice which has been given is valid. They have mentioned all the guidelines which you need to adopt. Here, even you can give an online prescription. You can give an online prescription to the carer and not always to the patient. Patient may not be always present during the consultation. The consult should be recorded, and the follow-ups also can be done by the carer. So it's a very good dynamic process which has been laid down both by National Medical Commission, which is an erstwhile Medical Council of India, and Ministry of Health and Family Welfare. So I think it is very safe, and that is how you see so many consultations which are happening. Now, does the patient experience change? Yes, it does, because there is nothing like a face-to-face consultation, because as we all know, 35 to 40% of the symptoms are psychosomatic in nature, which gets taken care of when you have a face-to-face interactions. So that may be slightly compromised, but nevertheless, I think India adopted this technology and we did fantastically well. So medico-legally, completely valid.
Thank you, Dr. Sanjeev.
Also, NABH also has come up with the similar standards to be adopted on a digital health medicine practice.
Thank you for that insight. So now the next question is directly to Mr. Abdullah. Prior to joining OMNI hospital chain, you were there with OHM, which was the first one to set up India's first EHR company. How is the experience, and which one is the better, being a technology provider or working with the patients from the patient's perspective?
Thanks, and it is a very wonderful question. And see, if we'll talk about if I was working as a product company which was developing the product for the end users, so it was the experience was altogether different, and always thinking and putting the my shoe into the organizations, keep talking and asking the to develop the EHR, the function feature into that. So that was keep happening, and but whenever it was not getting adopted, then I used to feel that is there any issue in terms of the solution what we have given? This feature has been asked and it has not been used fully the way it's supposed to be. But we found the root cause, and then we developed, and then finally the adoption went very high. If we'll talk about this, whether what is my experience if I'm working as a hospital now, I'm in the customer side, so that I have taken a U-turn to understand that what is the major challenges from the hospital organization side, why it is not being adopted, the EMR per se, why the doctors are having the constraint, and why the adoption is not, especially the clinical. Non-clinical is already adopted across the any hospital, but clinical adoption is still behind, though it is accelerating slowly. So the experience working here with as a customer is more compassionate, more passionate, and it gives a lot of learning that which I maybe keep talking to the product companies to where and how they are supposed to make the solutions to having three goals that the project, I used to say, and every time, and this is a kind of a change management, that the product company, if I'm making a beautiful solution and it is not being adopted by the customer, then it does not make any sense. And also, I'll give an example that NHS Lorenzo was developed in India. It spent £5 billion, and it went for toss. Finally, the doctor could not use it due to XYZ reason into the product. But I keep talking that the three goals, all the product company who are developing, they keep mind that the product is made in such a way that it should not require any training to the doctors or any training to the end users. It should be faster than paper, and it should give a sub-second response. If these three goals have been put in, then that is what I keep doing a change management with the product companies.
Yeah, thank you, Mr. Saleem. Due to paucity of time, I'm interrupting you. Sorry about that. So just one more question, which I will give it to Dr. Gayathri. If you're okay with this question, how effectively can hospitals use collaboration solutions for telemedicine? So what I think the participant is asking, is there any collaborative options for hospital to leverage telemedicine, is what I understand from this question. So we have only 1 minute, Dr. Gayathri, sorry for that.
No problem. So we need to understand that hospitals, they are a business also, but at the same time, hospitals are not at a position where they are open to experimentation for smaller sectors where the technology has not been proved. So they need to be very, very clear. They need to show proof that it has worked, and only then we will be able to adopt and then collaborate with them. Without that, it will just be wasting the hospital's time. More importantly, the patient experience will take a toss for sure. And we're going to lose a lot of goodwill that is generated towards the patient. And so it has to be tried and tested before they come to us.
Thank you. So I think we come to the end of the session because we have been given 1 hour. We have already crossed that timeline. So Dr. Chandrika, I had a few questions for you, but then due to paucity of time, I'm over to you. I think we had a wonderful interaction. A lot to learn from the panelists. It was wonderful moderating such an esteemed panel. Thank you so much.
So before we come to an end to this particular panel discussion, On behalf of APAC News Network, we would like to present a small token of appreciation to our healthcare leaders for their contribution and dedication in the healthcare sector so far. So, can we have the certificate, please? So, the certificate of appreciation is for Mr. Devanand KP, Regional CEO, Telangana and Andhra Pradesh Cluster, Aster DM. Thank you, sir, for your continuous effort and dedication in this particular healthcare sector. Then we have Mr. Abdullah Saleem, Group CIO, OMNI Hospitals. Thank you so much, sir, for your contribution in the healthcare sector.
Thanks.
Then we have Dr. Gayathri Kamineni, COO, Kamineni Hospitals. Thank you, ma'am, for your efforts and your contribution in the healthcare sector. Then we have Dr. Sanjeev Singh, Medical Director, Amrita Hospitals. Thank you so much, sir, for your contribution.
Thank you.
And then we have Dr. Chandrika Kambam, Director, Clinical Services, District Hospitals. Thank you, ma'am.
Thank you. Thank you very much.
With this, we are coming to an end of this particular panel discussion. Thank you all for joining us and making this panel discussion really insightful and interesting.
Thanks. Bye-bye. Thanks,
Thank you.
Devanand sir.
Bye.